All right, we are ready to move on to our guest speaker. So, Rachel, I hope you're ready to go there. My friend Rachel is stuck in an airport, but she's ready to go. And Rachel, would you like me to share the screen, or you think you can do it?
Um, you can go ahead and
I'm
do it. It
happy,
might just be
easier.
easier
Yeah,
in the
happy
event
to.
of shenanigans.
Yep, happy to do it. So, Rachel Cooper is the Senior Director for the National Stigma Initiative. And this is, you're out of Washington, D.C., if I'm correct, correct?
Well, right now I'm at Dulles, but normally I'm in Madison, Wisconsin.
Right, right, right. So, she is a Madison
So
resident. She's been on our team before. So, I'm just going to turn it right over to you to introduce yourself, and I'll get your slides ready to go.
awesome. Thanks. Yeah. So thanks, Terry. Thanks, John. Thanks, Paul. Thanks, everyone. And it's good to see some familiar faces. So like Terry alluded to, I was part of this task force a number of years ago in the harm reduction space, working at what was then the AIDS Resource Center of Wisconsin, now Vivant Health. And yeah, I'm excited to be back as part of a national organization that's really focusing on stigma reduction in large part. So Terry will be able to also send out the slides after we go through. So I'm not going to spend a ton of time on the initial ones. I know that she's pulling them up now, but in brief, and I think we can probably go straight to slide 2, Terry. Probably 3. I think slide 3 would be great. Yeah, just kind of looking at what we're going to talk about today is we're going to talk a little bit about Shatterproof, the organization that I work for, a little bit about addiction stigma, what it is, what it isn't, how to measure it, kind of what we're seeing as far as some of the data, including data from the task force itself, and then kind of what works to reduce stigma and some of those implications and action items. So Terry, I think we're seeing the chat right now, so we can go to slide 4, and then I'll just keep going and doing our next slide thing. Awesome. So Shatterproof is a national nonprofit, right? We're dedicated to reversing the addiction crisis in the United States, and we have 3 main pillars that are on slide 5, which is looking at the treatment system, so increasing access to and quality of treatment, supporting and empowering communities, and then breaking down addiction stigmas, which is what we're here to talk about today. So, as all of you know, right, we talk about addiction stigma all the time. Like stigma is a barrier. Stigma. What is hard is to actually know what works to actually reduce.
Hey, Rachel.
Of course, not
Rachel, we're
an unstable internet thing. So if I drop,
Yep, yep.
yeah.
I'm wondering if you might want to just
Next
turn your video off,
slide, please,
and
Terry.
yep,
See
and
if
if you
that
want,
works.
you might want to turn your video off and see if that helps.
Yep.
Okay.
So we'll see, and if not, I'll just call in on my phone.
Yep,
Again, sorry for
perfect.
the very long delay issues today. So what we did here, and this is a perfect slide to be on, Terry, is to really look at what has worked to reduce stigma in other social change movements, right? So looking at mental health, looking at LGBTQ rights in marriage, looking at HIV/AIDS, looking at other experts in the space. What actually works to reduce stigma? So we looked at all of these things, right? And it came up on the next slide, Terry, with essentially that there's 6 key success factors to actually reducing stigma. So this is some of the stuff that the stigma action team is going to be able to leverage as well. One is that having a well-funded central actors really benefits the creation of rapid change. It reduces the recreating the wheel stuff that kind of happens. Looking specifically at key actions in education and changing language and changing policies. Yes, of course, Christine, all these will be sent out. Education initiatives, so using contact-based strategies, a lot of us talk about. We actually just saw in the video, right, like the peer-to-peer stuff. What does it look like to humanize, to use contact-based strategies? And then using, the idea of activating influential institutions. So when I think about Waukesha County, I think about a lot of the institutions that are represented on this call, right? Who can lead in this space to really achieve public adoption? Sometimes incentivizing is really critical. So both positive and negative incentives do change behavior. And then also recognizing that we have to really mobilize both in grassroots, so very ground level work, and then also what the grass quote unquote tops, right? So making sure that everybody's adopting from top down and also from bottom up. as far as addiction stigma specifically on the next slide, we realize that this is it's a key driver of the overdose crisis, right? So a lot of things drive overdose. We all know this. But when we look at some of these drivers, we see that really 7 of the 9 of them are driven in part or entirely by stigma. So things like shame and social isolation, people not seeking treatment, when they do, insufficient treatment capacity. Sometimes we see non-evidence-based treatment. I know a lot of people here have experience with some of that non-evidence-based treatment stuff that's out there. Obviously, the criminalization of people with a substance use disorder. But really, at the end of the day, all of this is a social and structural barrier to recovery, right? So with the goal being to get people to a healthy place or to recovery, depending, stigma really is a major barrier here. So on the next slide, really, we have to define addiction stigma, because often all of us think about stigma in different ways. Some of us think about it in some way, some of us think about how we felt when we experienced it. So we're going to just level set here. And the next slide really is the definition that we use at Shatterproof, which is that stigma it's a mark of disgrace that's associated with a circumstance or a quality or a person. So when we think about substance use, we're thinking about people who either use substances or people with a substance use disorder. In essence, at the end of the day, it's a barrier both to receiving healthcare as well as engaging in those help-seeking behaviors, right? And it results ultimately in discrimination and exclusion. So on the next slide, I'm going to define a couple different types of stigma. And we talk about this in a few different ways. So the first is the idea of public or individual stigma. And that's really what we think about, most people think about when they think about stigma. So, society's negative attitudes towards a group of people that creates an environment where people feel unwelcome or judged, shamed, blamed. It does include, stigmas towards medications for opioid use disorder. From the structural stigma side, we're looking at that systems level discrimination that's like caused and codified by institutional policies or dominant social norms. And the key is here that we can't forget that we create the structures, right? So maybe we're not the people who are creating big P policy or little P policy, but we elect people, we vote, we advocate for things in our community. So what we believe, like our attitudes, our norms, our beliefs get codified into institutional policies, right? So at the end of the day, we are still responsible for not only creating policies and kind of some of us creating some of the structural stigma, but also we have the kind of the responsibility to then reduce it as we change our own attitudes and behaviors. Lastly, we talk about self-stigma, and self-stigma really is where people kind of accept those societal stereotypes and experience the reduced self-esteem and self-efficacy. So like self-esteem here would be like blaming yourself for your substance use disorder or feeling unworthy, right? Self-efficacy was more kind of like, I don't think that I can change. So I don't think that I am able to make the changes. So therefore I'm not even going to try, right? I'm not even going to seek help. Or if I did seek help, nobody would help. So those are some examples of self-stigma. So on the next slide, I want to just talk a little bit about how like stigma actually comes to be, right? Because it doesn't just magically pop into existence. So stigma really begins with stereotyping or like creating, kind of damaging and often inaccurate beliefs. And this often occurs through like labeling and language. And I want to note here that most of us learn these stereotypes when we're like real little, right? We're like 3 or 4 years old. We listen to what people, adults, TV, whatever say around us. We learn things when we're young, right? So these stereotypes are somewhat unavoidable. And, particularly with substance use, it's really centers typically around perceptions of dangerousness, perceptions of hopelessness, the kind of that clean, dirty language. But it's important to realize that the stereotype itself isn't what really creates the marginalization. It's really at the end, it's the prejudice and then the ultimate discrimination that does. And that prejudice really occurs when a stereotype leads to fear and shame, the kind of internalized blame that I was talking about. And this really tends to lead towards disparate opportunities such as decreased access to healthcare, unavailability of employment, reduced ability to secure safe and affordable housing, all of those kind of structural discriminations that we see, but also individual level discrimination, such as not wanting somebody with a substance use disorder to be in your family, to be in your neighborhood, to be in your workplace. So if you want to just click one more time, Terry, I just wanted to note here that some of the critical examples in the substance use space really do center around competence or dangerousness. And what this drives is a desire for social distance. It derives a desire, for not being around people, right? And then really enhances those discriminatory attitudes and behaviors. So on the next slide, I wanted to just note a couple things quickly. We've kind of touched on a few of these. We've touched on kind of labeling, but to be clear, I don't have to say the words to y'all. You know the words better than I do. We're talking about words like addicts, like junkie, etc. Labeling hurts. People say like sticks and stones may break my bones, etc., etc. Like words hurt, right? We can't get away from that. But words can also help. We talked about stereotyping. We talked a little bit about the distancing and the discrimination. But that fifth key component really centers on status loss. So what status loss looks like in this case is like, I don't want somebody with a substance use disorder to be my boss at work. I don't want them to marry into my family. I don't want them to hold an elected position. So even when people in recovery, we still see the status loss, this desire to not have people with a history of substance use, even if they've been in recovery for X number of months or years. We still see a desire to not have them hold positions like that. On the next slide, I just wanted to note really quickly that there is one more thing to really kind of think about here. We've had the traditional prejudice, competence and dangerousness, looked at social distance. We looked at internally, talked a little bit about how we internalize prejudice. And there's obviously a ton of literature on this that I can provide as well later on. But the last bit here is the perceived discrimination. And what the perceived discrimination part of this is really that it's the idea that if I disclose, then there are going to be consequences of some type. And maybe I won't get the job that I'm applying for. Maybe my partner's parents won't like me. Maybe I won't be accepted to a program that I'm applying to. And the reason why this is important is because it prevents people from trying at all. And it also speaks to those broad social norms, right, that we don't even necessarily think about, right? It doesn't trickle down necessarily. So let's say we change attitudes, right? Does it actually trickle down into somebody thinking that they can succeed? That is a totally different question than, do I blame myself for my substance use disorder? So there's a lot of work to be done in that perceived discrimination space. So, obviously kind of going through this pretty quickly here. Obviously we're a little strapped, for time and whatnot. But I wanted to share a little of this video that Carrie can play in just a second here that really talks about, it really humanizes what I'm talking about, right? So this has all been very academic so far, level setting, labeling, putting terms to ideas, to broad concepts. But in this particular instance here, if you wanted to play this video, I just wanted to share some words of somebody that has really experienced this firsthand.
Right, and just let me know if you're seeing and hearing.
Words can become grenades, strategically spoken at times to do the most damage. And when those words come from family and friends, they cut deeper. Labels erased my humanity. Total.
All right, let me try this one more time. On. Let me try this way.
That's good. Thank you.
Words can become grenades, strategically spoken at times to do the most damage. And when those words come from family and friends, they cut deeper. Labels erased my humanity. Total strangers felt allowed to criticize or judge me, saying that I was just a drunk or addict. These words also carried the connotation that I was lazy, selfish, or a criminal. After a while, I began to believe the words, concluding I no longer served a purpose or deserved hope. Luckily for me, these feelings were eventually replaced with words that provided healing.
The research is clear. Not only do words shape how we view people, but words also shape how we treat them. For example, studies show that when someone is described as an abuser or addict, the general public and even clinicians are more likely to believe that they should receive punishment over treatment. Tragically, for those with addiction who are looking to lead fulfilling lives, hearing the terms drug abuse or addict is paralyzing and demotivating. It blames people for their own illness, ignoring environmental and genetic factors. It feeds into the stigma they experience from society, their family, and treatment providers. To help decrease stigma around language, the Office of National Drug Control Policy recommends using person-first language to replace judgmental and negative terms. For example, a person with a chronic medical illness that impacts their brain is not an abuser or an addict. They are John with a substance use disorder. John, a person who requires treatment and support to recover from his illness. Words matter. They can hurt and reduce someone's motivation.
Together, let's choose supportive, non-judgmental words that lead to treating people with respect and compassion.
Thanks so much, Terry, for sharing that. I appreciate that. So I'm just on this slide right here, I just really wanted to hammer home the point essentially that stigma at the end of the day manifests as discrimination and isolation, right? Like negative perceptions of people with a substance use disorder, they're extensive, they're deep-rooted, not only among like the public, right, but among employers, healthcare professionals, friends and family, and people with a substance use disorder themselves. And this really does affect and dictate how policies are created, how care is provided, how people perceive treatment. So these feelings, these deep feelings of exclusion and shame can stick with people for years and years, through treatment into recovery and recover again, regardless of their recovery status, which really powers this cycle that we're all here because we care about and because we're working to end. But it does make substance use disorder much more difficult to address and does really fuel negative outcomes. So the next bit that we're going to talk about here is talking about a tool that we have called the Shatterproof Addiction Stigma Index, which was created in large part because we realized, well, how the hell do you actually measure stigma reduction, right? It's one thing to throw a billboard up or to do a PSA on the radio or to do some sort of education intervention, right? And it's one thing to measure knowledge change. It's easier to measure knowledge change. We can look at pre and post, somebody learn something, right? We know what we want people to learn. It's another thing to measure attitudinal change, and measuring attitudinal change can be really complicated. So the tool that, very briefly, and for those of you who are data nerds, there's much more information to be had on this that I'm more than happy to send over. But on the next slide, it goes over really briefly that what we decided to do was really create a measurement tool to assess attitudes about substance use and people who use substances from the public, right? It measures perceptions of people with an SUD as well. So we were able to look at self-stigma. We oversampled for healthcare professionals to get a deep dive into what healthcare professional addiction stigma looks like. And it's a national survey, right? So we were able to use some of these validated stigma measures to really benchmark levels of addiction stigma across the country. On the next slide, just some brief stuff, methodologically speaking. We use these things called indexes or indices, which means that we're able to look broadly speaking at public stigma, structural stigma, and self-stigma, not simply as disparate, discrete data points, but as an umbrella, right? So measuring change in this kind of composite manner lets us set a baseline. It enables us to measure in a comprehensive way progress, in terms of, well, honestly, both increasing and decreasing addiction stigma. And we were also able to use what we call the vignette strategy, which starts, and for those of you who were able to take the survey, you read this, which says, you're going to read a brief description about a person, let's call him John. You're going to read the description of him, answer some questions about how you think and feel. No right or wrong answers, right? And then what this vignette goes on to do is to use the DSM-5 diagnostic criteria for a substance use disorder. And why we use this vignette strategy is because it for four real reasons here, right? One is that we have a neutral tone here. We're not saying addiction. We're not saying substance use disorder. We're not immediately provoking a bias by using some of those kind of like hot words, right? We're also looking at what a real substance use disorder profile looks like. So really eliciting reactions based on like actual symptoms of a substance use disorder. We also are able to, this like kind of look like we're not labeling, we're not saying, again, the word addiction. We're not saying anything that's like, again, going to predispose somebody to believe or think one way or the other. We're actually looking at the behaviors somebody would exhibit with a substance use disorder that is diagnosable. And then because we're doing all of these things, it really replicates how a person, just a random person out in the general public, would interact with somebody with substance use disorder. So it's a really cool tool that you guys kind of got a brief look into. And again, it looks at these different scales, right? So it looks at public stigma, structural stigma, stigma against MOUD, self-stigma, but then also we were able to look at some of those other subscales, including one about harm reduction, which we're going to talk about in just a second here. So the things that we learn from this is we learn to kind of like these things that sit into this public stigma thing on the next slide, Terry, this slide, perfect, is we look at kind of diagnostic labeling. So what is John experiencing? Is he experiencing illness? Is he experiencing a mental health crisis? Is he, what is it caused by? Is it caused by genetics? Is it caused by a lack of willpower? Is it caused by something else? We look at desire for social distance. So what level of proximity is acceptable? Is acceptable to happen in your workplace, in your family, in your neighborhood? And then what do we believe about him as a person, right? Do we believe that he's competent or dangerous or trustworthy or not? So these are the kinds of things that we're actually able to learn. And part of the reason why we utilize this tool today is because, for this meeting today is because we can actually look at, some of the stuff that we have inside this particular group of people, because we all have our thoughts and feelings, our own lived experience, both possibly as a person with a substance use disorder, as somebody who works in the field, as somebody who has a family member, etc. What do we actually believe? What do we have? Where do we have to start within ourselves to create, long lasting change? So some quick notes on the national data on the next slide, Terry. I just wanted to this is just some quick stuff so you can kind of hold this in your brain as we're talking about the task force specific data. We're looking at less than 1/4 of respondents really viewing substance use disorder as a chronic disease. Now, this can be both positive and negative, right? Sometimes people interpret the word chronic to mean like not treatable, right? And the last thing we want is for people to believe that this is not a treatable condition. But we still see, after this is some 20 years of SAMHSA and the CDC and everybody really pushing the definition of a substance use disorder as a chronic relapsing brain disease, a lot of people aren't believing that still. We still see that some half of respondents hold beliefs that substance use disorder is caused by bad character or a lack of moral strength. And in the social distancing sphere, that a lot of people are not willing to live next door to or be close personal friends with somebody with a substance use disorder. And this third bullet here is a place where I tend to spend a lot of time mentally, and that we do live near people who have a substance use disorder, and we are close personal friends. We just maybe don't know it. So when we think a little bit about what this really means, it talks a lot about, to me, about exclusion, in on a exclusion that we're not conscious that we're doing, right? What have we said? What have we done? What attitudes have we expressed to people who are already in our lives? What doors has that closed, and how can we reopen them again? Lastly, on this slide, stigma does persist even when a person is in long-term recovery. And what that looks like here is that even when somebody's in recovery, people don't want that person as a supervisor at work or to marry into their family. So, from the idea of what does that do? I mean, we think a lot about asking people to share their lived experience. We think a lot about asking people to share their story. And even when people are in recovery, that's not necessarily a mentally safe thing to do unless we can provide a safe space for that to happen. People are still scared to share. And how can we blame them when we know that 50+% of people don't want somebody in recovery marrying into their family? And then what does that mean for the work that we're doing? Where do we go from here? So that's the last bullet here is just that MOUD is often viewed as something substituting one addiction for another. But generally speaking, that fourth bullet point is one that is really important for me when I'm thinking about it. On the next slide, I know that there's been a lot of interest. I know we had some questions submitted specifically on harm reduction. So I did want to point out a couple of things, which is that we see roughly 2/3 of people are willing to purchase or obtain naloxone, which is solid. And then actually in terms of safe consumption sites or safe injection sites, we see some 43% of people think that there should be one in their community, which to me, I was actually shocked at how high that was. For those of us who have been in the harm reduction space for a long time, safe consumption sites are really controversial. So I was certainly surprised, pleasantly surprised, but definitely surprised to see that. And then, fentanyl testing strips are seeing almost 2/3 of people thinking that they should be free and available as well. So again, this is still the national data. We'll get into the Waukesha stuff in momentarily, but I know that there was a lot of questions came in that were very specific about harm reduction and the stigmas therein. So I wanted to make sure that I shared that with you. So I'm going to go to that next slide here, Terry, and I just wanted to, this is the part where this is kind of what we did. And, looking at kind of at what the task force believes. So, we're sitting here and looking at the respondents, right? And again, all of this data will be available later in detail, but we're looking at like some 6% of respondents thinking that bad character or moral strength played a role here. Now, I want to contrast that to the national data, which was over half of respondents felt that way. So what I'm seeing here very strongly is the people in this room, in this space, who think about this all the time, do not feel the same way as the general public. In fact, they feel it's always a dramatic change, right? We're seeing higher levels of people thinking that John's experiencing a physical or mental illness, and more people thinking as well that John's experiencing a chronic illness. So again, the people who are working and living in the space all the time are holding less stigma, significantly less stigma than the general public from a national level. So on the next slide, we're looking at social distancing, and again, we're seeing that people hold much less stigma than others. So if you want to go to the social distancing slide, we're looking at, like, most people are willing actually to move next door to John, to have him as a personal friend. The marriage number is still relatively low, but that was only 20% in the general public. So we're still seeing a pretty significant increase of looking at having somebody with a substance use disorder, an active substance use disorder, marry into the family. So there's something about being, this is not surprising to me, right? But there's something about being in the space that really does, the proximity, the learning, the knowledge, the exposure does really decrease stigma. And a significant increase in people were reported a strong willingness to have a group home, in their neighborhood, which is something that's really encouraging to see. On that next slide about the workplace, workplace is something that we talk about a lot right now. We still see, 2/3 of people are willing to have them as a coworker, but some of the proximity stuff, like kind of the closer that we got, hiring them, having them as a supervisor, working closely with, lower numbers than we would love, but still higher, still better than the national average. On the next slide, we're seeing very similarly that the traditional prejudice slide actually tracks really closely with the national data. The last couple here the last 3 here on the Waukesha County data, the next slide on structural stigma, we have strong support for broadening access to treatment, both through insurer and employer coverage of treatment. Everybody supported healthcare coverage for addiction treatment. We're looking at that. We want healthcare providers to care for people with opioid use disorder or substance use disorder, like anybody else with a chronic illness. And nearly everybody who responded believes that people with OUD should be directed to treatment instead of incarceration for drug-related nonviolent crimes. So exceptionally strong support in this group for supports to really help people with a substance use disorder. So to really break down structural stigma, there's a huge level of support. So for those of you who are in advocacy, this is a really important thing. On the next slide, specifically around medications for opioid use disorder, these numbers are also excellent, right? Almost everybody agreeing that it should be easily accessible, that it's an effective treatment. 92% of people would be willing to have an MOUD clinic in their neighborhood. This number nationally is right around 50%. And only 6% of respondents feeling like MOUD just substituted one drug for another, and that hovers almost at 50% nationally. So again, really, really encouraging stats here. And then lastly, the highlights on the harm reduction piece, we're seeing that 2 out of 3 people believe that there should be a safe injection site in the community. 95% of people said they know how to obtain naloxone, and 83% saying that they know how to administer it. And most respondents felt like Waukesha County is moving in the right direction as far as treatment availability, and people know where to find quality treatment for opioid use disorder. I mean, I know y'all don't have there's a lot of ways to compare this data, but having looked at a lot of communities across the country, it's really encouraging that this task force has such an intimate and aware knowledge of these pieces, right? Because this is not numbers that we typically see. So kudos to y'all for the work that you're doing. I just wanted to tie in quickly to the harm reduction piece, which is that, you know, I know this is a very passionate topic right now, when you look at some of these principles, humanism and individualism, autonomy, pragmatism, this requires that we trust people with a substance use disorder. So when we're talking about trustworthiness, when we're talking about, you know, do we think that somebody with a substance use disorder is trustworthy? You know, we're seeing that number in this particular survey we did was 58%. So we're seeing that 58% of respondents felt that John was trustworthy or competent. But you have to really lean into those beliefs to really do harm reduction work well, right? Because if you don't, right, then we don't believe that he should have autonomy. We don't believe, you know, in the individualism component as strongly as we probably should. So really looking at this piece as we think about it, to really thinking that, you know, as there is still a lot of stigma, I think more broadly around the harm reduction ideas, that a lot of this is actually going to go back to really addressing ideas of competence and trustworthiness and somebody's ability to make their own decisions. So I'm just going to take a couple slides, talk real quickly about like how we've operationalized this, just so that you guys have an understanding of like the different ways to leverage this data like this. An example of what we did is in our national index, we looked at healthcare professionals, right? And we noticed that healthcare professionals believe that substance use disorder is not a chronic disease, roughly the same way that the general public is. We would think that this would be different given levels of education and exposure, but that's not apparently the case, right? You know, we're seeing a higher levels of healthcare professionals who are unwilling to even next door to somebody with substance use disorder, you know, higher than the general public. You know, most people would be less willing to have people with a substance use disorder as a close friend. And actually a higher percentage of healthcare professionals endorse the harmful belief that MOUD is simply substituting one drug for another. Again, this is not Waukesha County specific, this is the national index, but this led us to, you know, in conjunction with like the next slide, which is saying, you know, that if you take a look at this, you see this manifest clinically. We see that people cannot get the necessary medical care to receive liver transplants, to do valve repair surgery, you know, reduced access to primary care and you know, the justice system involvement and whatnot for pregnant patients, et cetera. This is how addiction stigma manifests, right? So we take the slide before this, we take this slide and we take the next slide, which talks about how, you know, actually stigmatizing language actually leads to decreased treatment of pain, and how healthcare professional attitudes cycle, right? Medical students aren't intrinsically more stigmatizing of people with a substance use disorder than the general population. But there's something that happens, right? As people exist in the medical care space for longer and longer, which seemingly increases stigma to a certain extent. What is it? How does it work, right? So, you know, at Shatterproof, what we've done pulling this apart is we have a few different interventions in the healthcare space to try to pull apart what's happening here and then to try to address it. So we actually have some, there's a new article that literally I got in my inbox this morning, which I'm really excited to share with all of you guys, that really looks at some of this. But, you know, this is a really good example of how, like, if you're thinking, okay, but I work specifically in prevention, or I really work in the criminal justice system, this is the kind of work that can be done to kind of take a look at attitudes, to marry it with data, and then to create interventions to really look towards reducing addiction stigma. And again, that is also what the action team is here to help with and to do and to support. So obviously I'm here, I'm not going anywhere, and happy to keep helping with this. So two slides, I guess, before we go to Q&A. The first one is this next slide, where I wanted to just talk about, sometimes we're not in a place to really do it all ourselves, right? Like maybe we don't have organizational support. Maybe we don't actually work in the substance use field, right? And we work somewhere else, or you're not doing this all day, every day. So what does it look like to actually do some of this work individually, some of the individual actions that we can take? One of those things is using person-first and recovery-centered language. So again, person with a substance use disorder is one of those really good examples. Or, you know, not using words like a dirty test, right? Not using a word like addict. What that does is it really changes the paradigm in our brains. And this has actually been demonstrably impactful in the healthcare space with people who read a vignette saying substance abuser versus somebody with a substance use disorder, with people, and these are mental health and substance use professionals, people who read the term substance use disorder as opposed to abuser were less likely to recommend punitive action and less likely to believe that people with a substance use disorder were personally responsible. So language matters, right? It just does. And for those of you wondering, well, how do I step in? How do I correct? What do I do? I mean, sometimes it's written, sometimes it's an opportunity to step in and say like, hey, actually we use this language, or this is why we should use this language. Sometimes you can't do it in real time and you have to circle back to it. There's lots of different methods to really look at that language change. Secondarily, we're looking at eliminating barriers, those structural barriers. Again, those of you in the advocacy space, what does it look like to do the work? Sharing stories and sympathetic narratives is important. So sharing stories of treatment and recovery, sharing stories of hope, like we saw again in the video to start, but also sharing real stories. Like people with a substance use disorder, regardless of where they're at in their journey, are real people, right? What does it look like to share, to humanize, to contextualize, and then also to define people beyond substance use? A person with a substance use disorder is also somebody's child, somebody's a partner, somebody's coworker, somebody just in the community, right? So humanizing. And then for those of us who can, again, incorporating the stigma awareness and reduction trainings is important. And then on the next slide, before we kind of go into some of the Q&A, I wanted to note that for those of you who are thinking about this, right, we're looking at we're still looking at tailored messaging. So again, who are you talking to, right? If you're talking about in the prevention space, like primary prevention, it's a different message than if you're talking to treatment professionals. So what does it look like? Who are we talking to? Are we talking to people who live in I don't know, in New Berlin versus Oconomowoc? These are two different cities, right? Two different groups of people. Are we talking to people who are in treatment versus that? So what does tailored messaging look like? Looking at contact-based strategies and person-first education we've talked about. Evaluation is obviously really important so that we can establish what works and what doesn't. And then the idea of collective impact. And this group here in Waukesha County is a great example of using a collective impact model where everybody has kind of aligned on common goals. So everybody's organizations and everybody's work has their own goals, their own agenda, their own things that they're doing. The idea behind collective impact is that in this room, we have set aside those individual things and we have coalesced around a collective agenda, a collective goal. So again, for those of you who are sitting here thinking, oh my God, this is a ton of information, the slides will be out there and I'm on the acting team, so we'll be happy to support however needed. I did want to then note that we have a few minutes set aside here for Q&A. I know we got into my part of about 5 minutes later than we thought we were going to, but I did want to talk about a little bit, just to, again, touch on very quickly. There's a lot of passion in this group. Some of the questions that we had submitted really look at that harm reduction space. So why don't people want to be more welcoming and more tolerant? Why do we, how can we build understanding and really moving away from intolerance and disdain and fear, really moving towards, this kind of empathy and care, and why some of the tools specifically are more stigmatized, than others, right? Like I started doing this work a decade ago in harm reduction. When I look back at 2013, we've come way, way farther than I mentally thought at the time as pertains to acceptance of needle exchange programs. But at the time, it didn't really feel that way, right? So I think that a lot of that has to do with, and I'm not going to go too far into this because it's not really the point, but there's a lot of morality that's associated with substance use. And when you start to put moral feelings around different types of drugs, around different pathways, right? When you moralize the drug itself, it's complicated when some drugs are scarier, quote unquote, than others. We know that people hold higher levels of stigma towards people who use methamphetamine than people who use alcohol. We know this is demonstrably true, right? So when we look at some of these levels of stigma, one of the things that speaks to me very clearly is that if we sit in that moralizing space, as opposed to really stepping back and not thinking about the drug, but really thinking more about the person, then that's a lot of where those contact-based strategies, that story sharing. Again, John, the story that was shared earlier, Megan, that is a classic example. It's an excellent example of saying, this is a person who experienced all of these things, and look at where we are. As stories of hope, but not minimizing and not ignoring the difficulties, talking about them and talking about the tools. Again, communicable disease is a great example of like why syringe exchanges are important, but it doesn't necessarily get to the humanizing part, right? So really thinking about the humanizing and those kind of contact-based strategies is a critical space. So managed, Terry, to get through this right on the 30, but we did not do Q&A. So if you want to, happy to do some of that now.
Yeah, there's a lot that you delivered.
I know.
My mind is swirling. I have questions,
I
but
know. My mind is swirling too.
Yeah, thank you so much, Rachel. So we're gonna open it up. I'm gonna ask if you can use the hand raise feature. That would be really helpful. If you can't find it, just unmute and we'll get you in the queue. But and or use the chat if you would like to submit a question via chat. And I'm just looking at chat here. Yeah, Nicole Matson says this was wonderful. Thank you for your presentation. It was really fascinating. Our numbers as a team were interesting to me. I wonder what our numbers in Waukesha County community is. That would be my comment, not necessarily a question. So
same here.
Questions from our Heroin Task Force members. Giving you guys a second to take a breath here.
Y'all can also email at any given point. This is an ongoing conversation. So no pressure to kind of come up with something on the spot.
Yeah, and remember, we have a stigma reduction action team. This came a year ago. That surfaced to the top as a concern from this group. So Nicole Bry, you can send an email to her. She can get it to the right team. We can put Jake maybe, and you and Colleen might add some things. So I've got Stephanie Engel and then one in the chat. So Stephanie Engel, you go first.
Thank you. So this is, I guess, more of an inquiry. I attended the harm reduction conference, and there was this speaker who really spoke to what you were talking about the prevalence of stigma in the healthcare field. And he had talked about being a person in recovery. I think he was a physician and he had really struggled with substance use. And he had put forth some research that was very interesting because it really actually indicated that there's a pretty high prevalence of substance use in the healthcare community. And so I'm actually curious if you are aware of that research.
I'm pretty sure you're talking about Sean Fogler, who I adore and is a good friend of mine. So yes, to put it quickly, yes, I'm aware of Sean's work, and I'm actually happy to send on some of the stuff that he's worked on. But there's definitely a conversation to be had about substance use within the healthcare field, the resultant stigmas that exist. And in that workplace stuff, I mean, that is a lot. So I'm happy to send that on. And Terry, I'll probably just send it to you directly. And then you can send it out to the group. And Stephanie, if you're actually interested in connecting with Sean, I can directly make that connection for you.
That would be amazing. I was looking for his research and I could not find it anywhere.
Yeah, so I've got it. I'll send it along, but I can also make that connection.
Thank you.
Perfect. Great question, Stephanie. And then we also had one in the chat that she has already answered, that Rachel's already answered. There were 36 of our members that submitted the survey. So any other questions we'd like to, we just get Rachel back in here. Any other questions that we would like Rachel to address at this point? Jim says the number of healthcare providers who do not view SUDs as a chronic brain disease is alarming. I thought the same thing. They should be teaching this in medical school, right?